This conference will now be recorded.
Good morning, all. Am I audible to you?
Yes, ma'am.
Okay, thank you. So today's topic is barriers in spermicidal agents and LARCs. So first coming to, these are all contraceptive measures. So first method is barrier methods. It is mechanical method, chemical method, and combination of both. Most commonly used barrier methods are, all you know, is male condom. Next one is female condom, diaphragm, and cervical cap. These female barrier methods are relatively rare. Most commonly in our country, most commonly used barrier method and which we have government supply is male condom, which comes under the name of Nirod. And chemical methods, this is also relatively rare. Chemical methods like these are vaginal contraceptives, creams, delphin, jellies, and foam tablets. Among all this, most popular one is sponge, which is popularly known as today. Other combination methods, like we can use both mechanical and chemical methods together. That we call as combination method. First one is spermicides. Spermicide agents are chemical agents which kill the sperms before it enters the cervical canal. Sperms can enter into vaginal cavity, but before entering into the cervical canal, they all get killed. These chemical agents contain surfactants such as nanoxol, 9-octoxanol, enzyme inhibiting agents, etc. They are available in different forms like jellies, films, foam, and suppositories. Only 76% effective when used alone. Should be used in combination with other contraceptive methods like condoms. Failure rate is approximately 30 per 100 women years when used alone. So these chemical methods which are spermicides, when used alone, they have high failure rate. So these should be always used with barrier methods. Spermicidal agents should not be recommended to HIV patients as they increase the risk of spread of HIV. Coming to next barrier methods like male condom. These are made up of latex, polyurethane, and natural membrane condoms, Vilex, etc. Most common and effective barrier method when used properly. Failure rate is 10 to 14%. This failure rate is mainly due to improper uses of this barrier method, and these are very effective if used properly. To increase the effectiveness, a dose of spermicidal jelly or foam tablets can be used at the same time. In case of breakage, slippage, or defective use, women should report or use emergency contraceptive within 72 hours, and a spermicidal agent should be quickly inserted into the vagina. What are the precautions and we should take to properly use this barrier method? To use a fresh condom for every act of coitus, to cover the penis with condom prior to the genital contact, create a reservoir at the tip to withdraw while penis is still erect, to grasp the base of the condom during withdrawal to avoid spillage of the sperms. Advantages of male condoms are they give very good protection against STDs like syphilis, gonorrhea, trichomonas, moniliasis, non-gonococcal urethritis, and infections like chlamydia and herpes. They're only contraceptive to protect against HIV and against sexually transmitted diseases like hepatitis B. So these give protection along with contraceptive uses. They give protection against STDs and sexually transmitted diseases like HIV and hepatitis B. Condoms reduce the chances of developing cervical dysplasia and cervical cancer by preventing HPV infection. These are all added advantages other than contraception. Non-contraceptive uses like after vasectomy to use till semen analysis confirms azoospermia. If a male partner underwent vasectomy, it takes 3 months to get, uh, produce a semen without any sperms. So for these 3 months, the male partner should use other contraceptive methods like barrier methods. As condom catheter in males after vaginoplasty, as condom tamponade for managing atonic PPH. In patients with anti-sperm antibodies present in cervical mucus. Disadvantages like male condom can lead to contact dermatitis in female partners. High failure rate due to bruising or slipping of condom. Inability to maintain full sexual satisfaction. These are all the disadvantages. Coming to female condom, made as an alternative to male condoms, consists of polyurethane. Is sac about 15 centimeters long and 7 centimeters in diameter with two flexible rings. The ring at closed end covers the cervix internally like a diaphragm, and rug at open and covers the vulva. So this is the female condom. So this is the vulval end. This is the internal end. It is pre-lubricated with silicone-based lubricant. The condom is to be inserted like a tampon before intercourse and removed after 8 hours. After intercourse, several sexual intercourse takes place within the cavity of the device. The advantages are it prevents STDs and HIV. Its use depends on the will of the female partner and does not require male cooperation. These are the female condom. So we have to insert female condom like this, similar to usage of tampons. So this will cover the cervix, and this is the vulval end. Fem shield, also known as Femidon. It is newly developed female barrier contraceptive. It is loose fitting 15 to 17 centimeters long shield made up of polyurethane, pre-lubricated, and has combined features of diaphragm and a condom. It covers entire vagina, cervix, as well as the external genitalia. It can be removed immediately after intercourse. Failure rate is 5 to 15%, which is relatively less. Advantage of Fem shield, or it is a coital independent and can be worn well in advance of a sexual act. It does not slip off easily, and failure rate is expected to be low. Stronger than condom and does not burst easily. Unlike the diaphragm, it can be worn during peritoneal period also. It is highly protective against spread of STDs and AIDS. Disadvantage is it is expensive. Coming to next barrier method, diaphragm or the Dutch cap. It is a dome-shaped diaphragm of thin rubber with a rubber-covered metal rim, which may be either a watch spring or a spiral spring. Made in wide range of sizes varying from 50 to 95 mm, that is 5 to 9.5 centimeters diameter. The best time to introduce it is from a few minutes to 2 hours before the sexual act. Spermicides should be used along with this device. After intercourse, the vaginal diaphragm should not be removed before 6 to 8 hours. So if we remove diaphragm immediately after the act, the sperms can go up to the cervix. So for 6 to 8 hours, we should not remove, but not beyond 24 hours. Failure rate with the use of Dutch cap is 4 to 6 human years, 100 human years. How to clean a diaphragm? This diaphragm is reusable. Clean the diaphragm with soap and water, let it air dry, and then store it in its case. Avoid oil based lubricants which can damage silicone. So one of the advantage of diaphragm, it is reusable. Advantages are cheap, can be used repeatedly for a long time, reduces pelvic inflammatory diseases and STDs to some extent, protects against cervical precancerous and cancerous lesions. Disadvantage, sir, requires help of a doctor or paramedical person to measure the size of required. Risk of vaginal irritation, aberrations, and UTIs are there. They do not protect against HIVs, do not suitable for women with uterine prolapse. Rarely they can produce toxic shock syndrome, similarly like tampons. Contraindications are prolapse, cystocele, rectocele. In this case, we cannot use these diaphragms. Retroversion, cervicovaginal fistula or rectovaginal fistula, badly eroded or lacerated cervix, recurrent UTIs. Coming to cervical cap, cup-shaped rubber like a thimble with a solid rolled rubber ring, available in 4 sizes varying from 22 to 31 mm. Fits loosely to the cervix and is suitable where the cervix is long and firm. Filled with spermicidal jelly prior to use. Preferred to vaginal diaphragm in uterine prolapse. Advantage of cervical cap is it can be used in uterine prolapse also. It can failure rate is 8 to 20 per 100 women years. Contraindications of cervical cap is chronic cervicitis, cervical erosion, and cervical laceration. So this is the cervical cap. So it fits firmly to the firm cervix rather than a porous cervix. Another one is today also known as sponge. It is a mushroom shaped polyurethane disposable sponge 2 inches in diameter and 1.25 inch thick. It contains 1 gram of nanoxyl 9. It provides with a loop or for its easy removal. It should be placed high up in the vagina with concave side covering the cervix. It acts as a mechanical barrier and prevents entry of sperms into the cervical canal. Absorbs semen and contains a spermicidal agent. It can remain effective for 24 hours. It is used only once. Failure rate is 9 to 30 per 100 women years. Coming to IUCDs. Intrauterine contraceptive devices are made up of plastic, metal, or combination of these materials. Effective, safe, convenient, reversible long-term methods of contraception. It does not interfere with sexual activity. The device is commonly made up of polyethylene, which is impregnated with barium sulfate to render it as radio opaque. So we can see it on X-ray also. The plastic devices are flexible so that they can be straightened and loaded with the introducer and pass it through the cervical canal and gently released within the uterine cavity. Each device has nylon thread attached to its lower end, and it protrudes through the cervical canal into the vagina, where it can be felt by patient and doctor and can be removed by pulling it with the forceps. It is extremely effective without using the hormones, more than 97%. The intrauterine device shown uses copper as the active contraceptive. Others use progesterone in a plastic device. IUCDs are very effective at preventing pregnancy. IUCDs come with increased risk of ectopic and perforation of the uterus and does not protect against sexually transmitted diseases. They are prescribed and placed by healthcare providers. So this is the copper IUCD. It is placed in the uterine cavity like this. Types of IUCDs. First generation IUCDs like inert IUCDs like Lippis loop. Others are Chinese single coil ring, Safety coil, Mawa ring or Otter ring are mostly, these are all mostly abandoned nowadays. we mostly using copper releasing IUCDs and hormonal IUCDs. Copper containing IUCDs like copper 7, copper T 200. These are all multi-loaded copper 375 Nova T. These are all different types of copper releasing IUCDs. These are most commonly used nowadays. Hormonal releasing IUCDs like progesterone and LNG IUS. Among these two, we most commonly use Mirena. For other than contraceptive uses like menorrhagia, AUBs, we generally use this Mirena IUCDs. Fibriplant is frameless LNG IUCD, releases 14 micrograms of LNG, levonorgestrel, daily and is under clinical development. Approved lifespans of these IUCDs are copper T380A is 10 years and copper T380AG is 4 years. And what we routinely use is multi-load 375, it is 5 years, progesterone 1 year and LNG IUCD is for 5 years. Coming to inert IUCDs, acts preventing sperm from fertilizing over. Non-medicated IUCDs acts as foreign body in the uterus and produces sterile inflammatory response and tissue injury of minor degree sufficient enough to the spermicidal action. They prevent sperms from reaching to the ova and prevent both intrauterine and ectopic pregnancy. They provoke uterine contractility and increases tubal peristalsis, which in turn do not allow sperms to ascend up to the ova. They require push-out technique for introduction into the uterine cavity. It was the first IUCDs introduced in National Family Planning Program. Next, coming to copper releasing IUCDs, acts preventing sperms from fertilizing over. Elute copper, which bring about enzymatic and metabolic changes in the endometrial tissue and also produce biochemical changes in the cervical mucus and endometrial secretions. Copper devices act locally, no systemic or no changes in the hormones. Ideal candidate for copper T insertion are the person should have at least one child. Copper Ts are highly contraindicated in a nulliparous woman, monogamous relationship, no history of PID, who do not want to use hormonal contraception. Copper T is the best for these candidates. Copper T 380A for its insertion, no sedation or anesthesia is required. No touch technique is used to load the copper T in the inserter while the both parts are still in the sterile package. Clean the cervix with antiseptic solution. Avoid touching the vaginal wall or speculum blades with the uterine sound or preloaded IUD inserter. By passing both the uterine sound and the loaded IUCD inserted only once through the cervical canal. Next, coming to progesterone releasing IUCDs. Their mechanism of action is they cause decidualization with atrophy of endometrial glands, therefore inhibit implantation, alter cervical mucus causing inhibition of sperm penetration and capacitation. In 40% of cases, ovulation is also inhibited. Progesterone is the T-shaped device carrying 38 grams of progesterone in oil reservoir in the vertical stem. Progesterone it releases 65 micrograms of hormone per day. Copper T versus progesterone. Life of copper T is 10 years, whereas in progesterone it is 1 year. It is 99.2% effective. It is 98% effective. Copper T on IUCD acts as spermicide. IUD blocks X from implanting. T-shaped plastic that releases hormones over a year time frame, thickens mucus and block the egg. Must check strings before sex and shedding of uterine lining. Check strings before sex and after menstruation. Coming to Mirena IUCD, it is very commonly used nowadays. It is a levonorgestrel IUCD, was approved for medical use in 1990 in Finland. It is in the World Health Organization's list of essential medicines. Duration effect is 5 to 7 years. Failure rate is 0.2%, which is very, very, very less. Users should check the threads. Mechanism of action, it is a progesterone that is a progesterone receptor agonist, T-shaped piece containing 52 gram and 52 mg that releases 20 micrograms per day. To prevent fertilization, uterine environment becomes unfavorable, cervical mucus thickens, lining the endometrial lining, thinning of endometrial lining, use of Mirena is birth control. Other than birth control, it is mostly used for other uses like heavy menstrual periods, endometritis and chronic pain, adenomyosis and dysmenorrhea, and it can be also used to prevent anemia by controlling heavy menstrual periods. Advantages are one of the most effective form of birth control, can be used during breastfeeding. May experience lighter period for the 1 year of after insertion. Effective for 3 to 7 years. 90% of the users who wish to become pregnant do so within 24 months of removal. Disadvantages are irregular periods and spotting between periods, cramping and pain. Many women feel discomfort. Expulsion, perforation, pregnancy is rare. Infection, ovarian cysts, and mental health changes. Weight gain, headache, migraine, nausea, acne, excessive hairiness, decreased libido, may affect glucose tolerance. Contraindications to Mirena is pregnancy, cervical or uterine cancer, breast cancer, PID, STDs, and liver disease or tumor, unexplained vaginal bleeding. So preparation for Mirena placement, visualization of the cervix by means of speculum, grasp the upper lip of the cervix and straighten the cervical canal. The forceps should remain in the position throughout the placement procedure to maintain gentle traction on the cervix against the pushing force of the placement. Gently move a uterine sound across the uterine cavity to the fundus to determine the direction of the cervical canal and the depth of the uterine cavity and to exclude a uterine septum or submucous fibroids. Should the cervical canal be too narrow, dilatation of the canal is recommended. So first open the sterile package completely and push the slider forward in the direction of the arrow to the farthest position to load the Mirena into the insertion tube. Do not pull the slider downwards as this may prematurely release Mirena. Once released, Mirena cannot be reloaded. So this is the inserted tube. So at the tip of this tube, this Mirena will be there. You have to push this slider as far as possible so that the Mirena will be loaded here. Once we pull back this slider, the Mirena will be loaded into the released into the uterine cavity. Holding the slider in the farthest position, set the edge upper edge of the flank to correspond to the sound and measure the uterine depth. While holding the slider in the farthest position, advance the inserted through the cervix until the flank is approximate 1.5 to 2 centimeters from the uterine cavity. So we should not release Mirena as high as possible, like almost near fundus. We should maintain a gap of 1.5 to 2 centimeters from the fundus. Here we have to release the Mirena. Do not force the inserter. Dilate the cervical canal if necessary. While holding the inserter steady, pull the slider the mark to open the horizontal arms of Mirena. Wait for 5 to 10 seconds for horizontal arm to open completely. Advance the inserter gently towards the fundus of the uterus until the flanks touches the cervix. Mirena is now in the fundal position. Holding the inserter in place, release Mirena by pulling the slider all the way down. While holding the slider all the way down. Gently remove the inserted by pulling it out. Cut the threads to leave about 2 to 3 centimeters visible outside the cervix. Next, coming to the removal of Mirena. Mirena is removed by pulling on the threads with the forceps. You may insert a new Mirena immediately following the removal. Non-contraceptive uses of LNG, it reduces the blood loss in DUP and anemia, reduces the pain, endometriosis and adenomyosis. Beneficial effect on fibroids, do not influence lactation or affect infant growth and development when introduced 6 weeks after delivery. Drawbacks are it has irregular bleeding and oligomenorrhea common in first 3 to 4 months, amenorrhea in 20 to 50% of the cases by 1 year. Difficulty of introduction and needs local anesthesia. Acne, dizziness, headache, breast tenderness, nausea, vomiting, weight gain. Ovarian functions are not disturbed. Most common, most important drawback it is highly costly. Selection of patients for IUCD insertion. Copper IUCD is more appropriate, safe and effective with a low pregnancy rate than lipis loop. New copper devices are safe than more old copper devices and have longer duration of use. LNG IUD appropriate choice for women with pain and bleeding problems from use of copper IUDs. Cost factor is an important consideration. Individual packed and pre-sterilized IUCDs are preferable. In relation to menstruation, what are the timings of insertion of the IUDs? During or soon after menses, because it avoids the chance of insertion in the early stages of pregnancy. Cervix is usually soft in this stage, partially dilated, slight blood loss owing to the fitting procedure will not noticeable to the woman. Post-abortal insertion can be safely inserted during evacuation of the uterus. No increase in incidence of infection, perforation, or expulsion. High acceptance rate. Postpartum insertion has no advantage, including ease of insertion and convenience to the user, particularly of value in India, where postnatal care is not satisfactory. Following cesarean delivery, introduce IUCD after 1 to 3 months of delivery. Disadvantages of immediate postpartum insertion, uterine perforation and high expulsion rate. Introduce this postpartum insertion of IUD is best done by means of sponge folding forceps. Advantage is the device required only one time motivation and does not depend on continuing motivation of the user, does not require regular supply, nor there is any problem of disposal and affecting privacy. Does not interfere with sexual activity. The cost when spread over years, it is generally low. No systemic bad effects like OC pills. The return of fertility following its removal is immediate, highly effective. Life risk is minimal. No effect on amount and quantity of breast milk. Can be inserted immediately after childbirth or after abortion with no evidence of infection. Can be used through menopause. No medicine interacts with IUDs. IUD helps to prevent ectopic pregnancy. Coming to disadvantages. High initial cost, it is like one-time investment. Trained personnel for insertion and the subsequent treatment. Insertion is painful to some of them. Some need general anesthesia. Some cannot tolerate them. Complications like bleeding, pain, vaginal discharge, and mild infection. Dangerous complications like perforation, ectopic pregnancy, severe pelvic infections, very rare, but if occurs, they need immediate laparotomy. Expulsion in some cases leading to failure. Do not prevent STDs. So this is the main reason a woman has to check for threats before every act. Do not prevent STDs and HIV/AIDS. Complications of IUCDs or immediate complications or late complications. Immediate or difficulty insertion, vasovagal attack, uterine cramps. Early complications are expulsion, perforation, spotting, menorrhagia, dysmenorrhea, vaginal infections, and actinomycosis. Late complications are PID, pregnancy, ectopic, perforation, menorrhagia, and dysmenorrhea. So these are all the complications of IUDs. Thank you. Any doubts in this topic? This is very dry topic, but you have to know the basics of contraception, which is very important for your final exams. Any doubts in this topic? Any doubts? Okay, then thank you.